Have you ever been told that you're treatment resistant? Like you've tried therapy, you've tried CBT, you've tried the coping skills, but nothing works. And the subtext to all of that is you're just hard to treat. If you're autistic, ADHD, or ADHD, I want to give you a different way to look at this. Sometimes it's not person resistant, it's a model mismatch, meaning that the therapy wasn't designed, or better yet, adapted for the nervous system that you have. Hi there, I'm Dr. James Thatcher. I'm a licensed clinical psychologist at Forest Psychological Clinic based out of Portland, Oregon, and I've been doing thousands of comprehensive autism ADHD evals for over 10 years now. And over all of those years, I've done a lot of therapy, and I want to say this very clearly. I like cognitive behavioral therapy. I like CBT. CBT is evidence-based, and it's been proven to help a lot of people. And in this video, I'm going to go over why CBT can feel like it fails neurodivergent people, especially when it's used in a rigid, one-size-fits-all way, and how to make therapy fit you instead of you fitting into a protocol. So here's the plan for this video, is I'm going to go over just a really quick stat to normalize why CBT can feel, oh, it just doesn't work. Then I'm going to go into what I think is actually happening on why CBT might be missing the mark, especially for neurodivergent folks. And then I'm going to go into what I think works better, how to adapt CBT, how to use a neuroaffirming framework, and some different things to look for when you're looking for a therapist to make sure that it's the right fit. And before we get too deep into this video, I just wanted to say that therapy outcomes are very complicated. And all I'm doing is I'm just going over some common patterns that I've seen over the years. So before we get too deep into this video, let's do a quick reality check. In a big meta-analysis done by Ferdinand, Salem, Swift, and their colleagues, published in 2015 in the Journal of Consulting and Clinical Psychology, they looked at dropout in CBT across 115 studies. And what they found was that dropout happens before treatment really even starts at about 15.9%, so darn near 16%. And then during treatment, it rises to 26.2%. So what that means is you're not broken. Rather, it means that tolerability, life factors, things popping up in your life, therapist fit, all of those things matter. So if therapy didn't work, if cognitive behavioral therapy didn't work, or you quit therapy, don't rush to, well, I'm just treatment resistant. Rather, it often means that it just wasn't the right match. So now I want to get into some reasons why I think cognitive behavioral therapy fails neurodivergent people. CBT often works when the therapist can accurately see the patient and adapt it to fit that patient's reality, to fit their patient's life. But CBT can often miss neurodivergent people for three common reasons. Reason number one is starting with thoughts, when the system can start with overload instead. A lot of CBT starts with, what's the thought? Now let's challenge that. But a lot of neurodivergent folks are dealing with sensory overload, masking fatigue, social depletion. First, when somebody is already at capacity and they're being asked to make a perfect thought record, well, that's like asking someone to do math when they're drowning. And it's not that thoughts don't matter. It's that what's being overlooked is the state that the person is in. Reason number two on why cognitive behavioral therapy can feel like it's failing neurodivergent folks is that the model gets used like a script instead of a tool. Some therapists can use CBT like a worksheet. So where, all right, let's identify your cognitive distortions. Now let's challenge them. Now let's add in some coping skills. Now we're going to repeat all of this. But neurodivergent therapy needs more than just that. It might need some more concrete language. It might need some collaboration on what's going on with the patient. It needs more attention to sensory issues. And the goals need to be based on your values, not making you look normal. And reason number 3 is that rapport and felt safety can get ignored. Here's the part that doesn't get said enough, is therapy is not going to work if you don't feel understood. If you feel judged or corrected, or like your therapist doesn't understand your wiring, then your guard's going to stay up and you're not going to be able to get anything out of therapy. Now let me give you a de-identified example on what I mean by making CBT fit the person. A long time ago, I worked with a teenager. He had autism, ADHD. He was a really sweet guy. And his main goal was, how do I make a friend? His goal wasn't, how do I feel less anxious in theory? Rather, it was, how do I talk to people? How do I connect with another person? How do I initiate and maintain a relationship? And with him, he was just so sweet. But when he talked, it was overly formal. He wouldn't ask questions. And it was really hard for him to have a back and forth conversation. And none of this wasn't because he didn't care. It was because he didn't have the structure. He didn't know what to do. So what we did is we practiced, right? And what I used is we used games, checkers, playing cards, chess. But I added some rules to it. Every time that you won a hand, or every time that you took a piece from checkers, or every time that you made a move in chess, you had to ask a question. And of course, the other person had to be comfortable in answering that question. And I also used some cards. So it just wasn't like a free-for-all. Like if you couldn't think of a question in that moment, you could draw a card. It had a question already on it. Like, hey, what do you think about kids watching so much TV or playing so many video games? Or what's your favorite thing about going on vacation? It's random stuff like that. Any sort of question that you could ask. But the point being is that it was scaffolded, right? It was semi-structured. So we started off with the basics. He would say something, I would respond. And then we built on that. He would say something, I would respond. He would respond to my response, and then I would comment on that. You see what we did there? That's what's called a 4-point conversation. And what it is it's reciprocal. And that's a skill to be built up over time. Here's the part that I really like, right? All of that is measurable. All of that is evidence-based. We can see it. We can see it grow and progress over time. That's why I like evidence-based therapies. He went from not being able to sustain a reciprocal conversation, not being able to even initiate, all the way up to holding a 4-point conversation. And he had what's called cognitive distortions. He would think to himself, nobody's going to want to do what I want to do. Or the people at my lunch table just think that I'm weird. Or if I initiate a conversation, I'm just going to get rejected. So what we did is we turned it into a behavioral experiment. All right, well, let's try these out. Let's see if they're actually true. And so one way that I helped him with this is I asked him, what do you like to do with other people? And he said, I like to go bowling. And so, you know what? Great. Like, let's explore that gradually. So we're going to start off really small. At the lunch table, all you're going to do is you're just going to comment on something. And then after a couple of days, then we're going to move up. And once that's comfortable, we're going to move up and you're just going to ask a question of other folks. Hey, what do you like to do? What did you think about that thing that so-and-so said in class? Something like that, just to get comfortable with initiating conversations. And then once that got built up, he popped the question, hey, do you guys want to go bowling? And I'll be honest with you, if I'm remembering right, the first attempt, it didn't go so well. Not because he messed it up, but because there was scheduling issues. One guy was like, yes. The rest of the folks at the table were like, no, I'm too busy this weekend. I can't do it, this or that. And then when they finally did set it up, for one reason or another, my guy couldn't go. But then we tried again. And then he was able to go. And over time, as I kept working with him, he didn't need therapy anymore. He didn't need to keep coming and seeing me. I worked myself out of a job. That's kind of my goal. And it's not because he became a different person. It's just that therapy matched the goals that he had, and he was able to build up those skills, and he met them. And that's what I mean when I say that CBT works when you accurately see your patient. So now let's talk about what the research actually says in using cognitive behavioral therapy in adults. In a 2026 systematic review and meta-analysis by Perez Castilla and colleagues that was published in Autism and Adulthood, it looked at randomized controlled trials of CBT in autistic adults. And their conclusion was basically, across most outcomes, effects are very uncertain, largely because the studies were very small and they vary quite a lot. The one thing that they was able to pull out of it is CBT was effective in treating symptoms of alexithymia, so being able to identify, emotions in other folks, for a short period of time. And what this means isn't CBT doesn't work for folks. It means that we don't have a universal answer yet. So being able to use CBT and adapting it and fitting it to the person that's in front of you, that's what matters most. Now, there's another evidence-based therapy out there called radically open DBT. So if you relate to over-policing yourself, so saying to yourself, am I doing this right? Am I saying the right thing? And in social situations, you either shut down because you don't know what to say, or you replay those conversations over and over and over again. What might be going on is that you're presenting as an over-control profile. And this is where RODBT, radically open dialectical behavioral therapy, can help with a lot of people. The largest randomized controlled trial people cite is Lynch et al. 2020 in the British Journal of Psychiatry. It showed a benefit in mood after folks were being treated for depression, but not over a long period of time, not at the end point of this study when they followed up on it. So I wouldn't frame RODBT as the answer for everyone. Rather, it's going to be a good fit for some folks, especially if they present with that over-controlling profile. So now I want to give you some practical red flags to look out for. So if you're searching for a therapist, if you're shopping around for a therapist, here's some common phrases that you might hear that should send alarm bells off that, hey, this is probably not going to be a good match. So if you hear the phrase, I treat everyone the same, therapy is therapy, that's a bad answer. Again, therapy should adapt itself to the person that's seeking therapy. It needs to be flexible. It needs to fit with that person's reality, their goals, their life experience. It needs to fit them, not them fit a protocol. Or another one could be, my goal for you is for you to act normal. Oh, that's cringy. Do not move forward with that person, please. Or if they say, hey, let's do exposure. And I'll be honest here, like exposure therapy, that can be great, right? There's lots of evidence behind that. But there needs to be a clear plan when it comes to sensory overwhelm, how to slow things down, how to incorporate your nervous system into the hierarchy of what they're exposing you to. Or another one is if the therapist says, stop doing that. When that is a regulation strategy. If you're stimming, if you're fidgeting, if you're using something to help you concentrate, my stance is do more of it. I often put as a recommendation, especially for kids or even adults when they go to work, if you have ADHD, you should be allowed to have a fidget or sit in the back so you can get up and you can pace around. Whatever helps you concentrate, because that's a regulation strategy. Now, here's some phrases that would be some green flags. Let's adapt this to your nervous system. Oh yeah, that's solid. Let's build skills that work even when you're overloaded. Amazing. Let's do that. Let's clarify goals and make a plan that fits your life. Perfect. Yes, please. So in short, if CBT isn't working for you or didn't work for you, I want you to hear this clearly. That may not mean that you're treatment resistant. It may mean that you were given a rigid model or therapist that didn't accurately see you. CBT is a powerful tool when it's flexible, trauma-informed, neuroaffirming, and it takes into account that person's lived experience. And I want you to keep in mind that you're not broken. You're asking for therapy that fits your nervous system. So if you like this video, please stick around. I've got another one that I hope that you'll like. All right, I'll see you there. Bye.